ear, nose and throat surgeon and a consultant ENT surgeon, and I'm currently working in the East Midlands, at North Nottinghamshire, at a hospital called Sherwood Forest Hospitals. There might be some of you joining from Nottingham, in which case, please do give me a shout if you're around Kingsmill or Newark hospitals. So how this goes back to September, where I met Ella. I met Ella on a medical mission, as we would call it, in Rwanda. We met in Kigali. And I've been doing medical missions for a little while, and we'll talk about them in a bit. And a few weeks ago, Ella contacted me and said, would I please do a talk to the university? I thought she said University of Bristol ENT MedSoc. And so I thought, oh, okay, that would be good. What do you want me to talk about? And she said, well, the talk is called Inspiring ENT. And I had to think about some way to inspire people to think about ENT or be interested in ENT, and certainly not put them off ENT. So what I decided to do was a combination of things. One, to tell you about me and my story, because there's no person without a story, right? And then to give you a few nuggets of ENT. And ENT is so wide that I chose a very few things in otology to talk about. And then I'll talk to you about some of the medical missions that I've been on and some of the things that have been both a joy and a challenge. So if you're ready, we'll kick off. So I was born on the 4th of July, 1966, to this absolutely lovely couple, Nicholas and Grace, who were both students at the University of Newcastle upon Tyne. At the time, Nicholas had come over from Cameroon to do his engineering degree, and Grace had come from Trinidad and Tobago to do a degree in music, French, and art. And so I was born, and I was obviously a daddy's girl. Absolutely loved my daddy, and he loved me to bits as well. And so it was no surprise then that when I couldn't do the maths for me to become an engineer like him, I chose to go into medical school instead. And this was me in 1990, graduating from medical school in Cameroon, because that is where I had grown up and done my secondary school, A-levels, and medical school at the University of Yaoundé in Cameroon. So you may not see, but here I was growing a little baby. I was in my final year medical school, and I was growing a little baby who is currently 31 and has her own little baby of her own. But between when I was a little girl and this time, I had, 2 years before I finished medical school, I had got married to my fiance at the time, and he was going off to Scotland to become a gynecologist. So straight away after I finished medical school and graduated, I moved to England to join my husband. And then everything went really fast. And as you can see on this slide, over the next 13 years, I had 2 children, in between passing the PLAB test, which is the test that the exam that you have to do if you qualify out of the EU, did orthopedics, general surgery, and A&E as SHO, and then passed my Part 1 FRCS in 1995. Then I did totally ENT for 2 years, during which I passed my Part 2 FRCS and obtained the coveted ENT training number in 1997. And as soon as I knew that my next 6 years were sorted, I had my next little boy, who is now 24, and he arrived in grand style in Newcastle, and he's still a Geordie fan, a Toon Army fan till today. And 3 years later, I passed my Part 3 FRCS, which was the intercollegiate exam, and a mere 13 years after I finished medical school, I started off as a consultant ENT surgeon. So I hear you thinking, why ENT? Why ENT? Because everybody knows ENT is only about snot and wax, right? That is true. There's a lot of snot and wax in ENT, but there's a lot more. The real reason why I chose ENT was because, to be fair, the ENT professor was really dishy. However, it didn't harm that it was a very practical hands-on specialty, and I love to get my hands dirty. You can see kids, old people, girls, boys, all manner of genders. There are such a variety of subspecialties: pediatrics, ears, noses, throats, facial plastic surgery, head and neck oncology, benign head and neck, all sorts of different things. And so there's lots and lots to choose from. And for somebody like me, who can talk the hind leg off a donkey and loved to talk to patients, for me, I wanted to do psychiatry before I came across ENT. It was a marriage made in heaven. So if we move forward now, just to talk about a few things that I've just chosen at random, talking about babies. You could have, and if you go back to your embryology, you remember that the outer ear is made up as the fetus comes together with these 6 hillocks on the side of the head, and you can have levels of genetic or congenital deformities such as agenesis or absent external auditory canal and pinna, down to a tiny little pit or a preauricular sinus in front of the ear, which may not cause any bother, but which may also cause trouble such as recurrent infections, leaking, and so on. And talking to a group of university students, I'm sure there are some of you who play rugby or know people who play rugby. So you wouldn't be too unfamiliar with the subhematoma of the outer ear of the pinna, which can then lead to what is called a cauliflower ear due to recurrent trauma of the outer ear or the pinna. However, one of the things that we see a lot of in ENT is otitis externa, inflammation and infection of the outer ear canal. And the outer ear canal, and I'll reference this slide to my colleague, Mike Saunders, who is down in Bristol with you, Ella, and a lot of the other slides that I use. The outer ear canal is made of the lateral part, which is cartilaginous, and the medial part, which is bony. And if it gets infected, as you can see here with all this yellowy, crusty stuff, then it can be very painful, very, very uncomfortable, and would need to have topical treatment. So this is one of the nuggets that I want you to go away with and remember. Otitis externa is treated by topical antibiotics and anti-inflammatory rather than systemic antibiotics, unless there is periauricular cellulitis, in which case you need to have systemic antibiotics. So remember that. However, the treatment of otitis externa is mainly prevention. So nothing smaller. Oh yes, this slide is just to show you some nice gruesome fungi that can grow in the ear. And you can see spores growing here. But nothing smaller than your elbow should go into your ear. And I never really understand why these little white things are called earbuds or earbuds, because they should not be going into your ear at all. And neither should little pieces of plastic or bugs or crayons, but we see lots of these all the time, especially in children. And patients who have mental health problems tend to put things in their ears. So talking about all the different bad things that can go to the that can happen to the outer ear, I thought we should just have a quick memory of what the normal tympanic membrane looks like. As you know, I'm sure you all know that there's an attic area, and which is the pars flaccida, and the pars tensa area. And you have the handle of the malleus with the umbo. Through the tympanic membrane, you can just see the long process of the incus here, and the annulus and the light reflex. So if you see a tympanic membrane such as this one, the patient will probably be very unwell with a lot of pain, with redness, erythema, bulging, and loss of the light reflex, which you can see in the normal picture on this side. And otitis media, as I have just shown you, can lead to complications either within the mastoid. So this child has got a subperiosteal abscess, retroauricular subperiosteal abscess, as a result of acute mastoiditis. And in this case, she's had it drained. You can see the incision there. But this would have been a really poorly child with a high temperature, the loss of the retroauricular sulcus, and the pinna being pushed forward. This is another nugget. A lot of the time we get patients referred to us with query mastoiditis who have normal tympanic membranes, and that really doesn't usually happen. So if you have a normal tympanic membrane and you have redness and swelling behind the ear, it's hardly likely to be mastoiditis. So although it is a really nasty diagnosis, you need to really understand the context, because the middle ear is coalescent with the mastoid, and that's how it happens. The other one I just wanted to talk very briefly about is glue ear. You'll hear a lot about glue ear, and you probably will see children with glue ear. Children often have glue ear because of the way their eustachian tube is horizontal rather than vertical, and as such, the middle ear doesn't drain properly, as well as other conditions that would predispose them to glue ear. But it's such a pretty picture when you see a tympanic membrane with this lovely goldy, yellowy aspect behind it, and a little fluid level here. Not quite as nice, this one, which is a very drastic retraction of the tympanic membrane, and even some hemorrhagic fluid behind it. And in this case, a mild retraction but with clear glue behind the eardrum. And here comes the other nugget. Children often get glue ear, but in an adult with a unilateral glue ear, you have to be very concerned that they might have something sinister going on in the postnasal space, because you remember the middle ear is drained into the postnasal space through the eustachian tube. And if they have any abnormality or a sinister pathology, nasopharyngeal carcinoma, for example, in the postnasal space, then that would obstruct the eustachian tube and cause them to have unilateral middle ear effusion or glue ear. So I couldn't do a talk on otology without putting in a grommet. That's a Wallace and grommet, as I call them, the little white ventilation tube. They're different sorts. You can have little blue ones or little green ones or little titanium ones. So just so that you have a vision of what they look like. And here comes the last little nugget. You do not have an ear with wax in the attic. Wax in the attic is always indicative of something worse going on, specifically cholesteatoma. So you can have what looks like a normal pars tensa, but if you have an attic cross like this with retraction, this is pretty much pathognomonic of cholesteatoma and needs to be investigated further. Whereas if you have, they used to, cholesteatoma used to be called unsafe ear disease, as opposed to safe ear disease, where you have pars tensa perforation. I love this slide. Again, I'll reference it to Mike Saunders. The reason I love it so much is not because it's just a tympanic membrane perforation here, but when I look at this picture, I can see eyes, I can see a nose, and I can see a great big O mouth. So that's what I see, and that's what makes me smile when I see this picture. So moving on about, that's no more boring ENT picture, otology pictures. Moving on about the humanitarian missions that I've been privileged to be involved with over the past few years, and through which I met Ella earlier this year in Rwanda, as I said. This gentleman here is called Wale Olarinde. He's an ENT surgeon in Chesterfield. And sometime around 2014, he called me and said, "Do you want to join the WACS?" And I said, "WACS? What's WACS?" And he said, WACS is the West African College of Surgeons. And every year, WACS does an outreach mission to one West African country or the other. One year it's a Francophone country and the next year is an Anglophone country. And this picture here was with Dr. Mane, the single ENT surgeon in the whole of Gambia that we worked with during the time that we visited Gambia. I think that was in 2017. And this was the group of WACS volunteers, WACS UK volunteers that came from England. They were not all ENT. They, as I said, since I joined WACS in 2014 and went every year with Wale and the rest of the team, we have ENT, general surgery, ops and gynae, ophthalmology, and it's a whole week of really getting in there, working hard from pretty much from dawn to dusk, seeing everything that shows up, doing some operations, doing some really, really challenging things, seeing some really heartbreaking situations, but in among all of this, there's a lot of teaching and training as well as learning that happens. In 2018, I was approached by Dr. Chris Opong, who works with a charity called the Rwanda Legacy of Hope. And himself and Pastor Ozi set up something called Operation Hernia. And their mission was to teach and train the local surgeons to do basic hernia operations over and over and over again, so that they could then teach and train their colleagues to do it properly. And in 2018, I joined the team as the first ENT surgeon, and subsequently Miss Kate from, where's Kate from?
She's from Poole.
From Poole. Thank you. Kate joined the team to do mainly laryngology. I do otology, and I've been to Kigali in Rwanda and Butare to work with the teams there. So this here looks like a total bedlam. So my life, my normal life is I'm a beggar, a borrower, and a stealer. What I do in any hospital that I work in any department that I have any connection with, I tell them I go to Africa every so often, usually once or twice a year, and I would be most grateful if you could see it in your heart to put aside any instruments, any equipment that you don't need, that you don't use, that has expired, because I am going to use it for demonstration purposes. Because otherwise, they would put them all in the skip if they have expired. And so this is my living room, and these things have all been brought out from my shed. And here's my darling sister, who every year organizes. I'm rubbish at organizing things. So every year she sits down and puts them all together. And Ella saw my suitcases the last time when we were in Rwanda, with all the stuff that I've accumulated, and I wrap it up in as many bags as I can, or as much as the airlines will let me, and I fly off with them. I come back with some African artifacts or stuff that I buy in the place that where we've gone. But these are a few of the things that we see. And when I tell you that there's some heart-wrenching things, this little baby has a cystic hygroma. We found her, the local surgeons had been able to put in a nasogastric tube for her to feed because she couldn't feed, but there wasn't really very much else that could be done. And after a week, after we left, I don't know what happened. I honestly don't know what happened to that baby. The parents had brought her from some in hinterland somewhere, and there wasn't anything we could do for her. This lady, however, with a huge thyroid, had a thyroidectomy, one of possibly 12 that Wale, who's the head neck surgeon, did that week, and who would not have had her operation otherwise. Here I was on a mission in Sangmelima in Cameroon. No, it was in Chang in Cameroon. And this lady had been hoarse for a very long time, and nobody knew what it was. As it turned out, if you can notice here, she's got a scarf. She has a papillary, she turned out to have a papillary carcinoma that had affected her her recurrent laryngeal nerve, and she was hiding the lump in her neck with the scarf, and I could see that she did not, one of her vocal cords was not working. So we had to move her to the center where they could do some investigations and so on. And this was a medical student who was with me, and I was demonstrating with him, demonstrating the vocal cord palsy to him. This instrument here, the nasal endoscope, I borrowed from Wale, my colleague, who had begged it off from Storts, and Storts had donated this scope, so he keeps it in his possession, and every time he goes away, he uses it. Otherwise, nearly everything that we take away with us remains. We take, this year, I got a rigid nasal endoscope from DP Medical, which was really very, very, very appreciated, and a headlamp for the department. And I ended up coming back without my own personal otoscope, because the department in Kigali, the whole ENT department in Kigali, had one otoscope that they had to charge, and sometimes it ran out of charge. So I left mine so that they could rotate the charge. This here is a very interesting picture. You'll be forgiven for thinking that this thing in the middle where the arrow is a coin. But if you look more closely, you'll see that it has a double ring around it, just here. And this actually is a button battery. These are the bane of our lives in ENT when it comes to children. Because if you don't take these out very, very soon, they can cause necrosis within the esophagus, and cause esophagitis, perforation. And if you manage to get it out quickly, and the child survives all of that, then they can end up with quite nasty. This here is a gentleman that we actually saw in Kigali this last trip, and he showed up with this thing that has been growing out of his ear for many years, and nobody had been able to do anything about it. And so I quite bravely decided that I was going to try and take it out. So there I was. I made an endoral incision. He was under general anesthetic. Endoral incision. I managed to get to the root of the thing. And as soon as I took it out, this is it looking like 3 centimeters. Can you imagine a 3 centimeter mass in the outer ear? It started hosing at me. So it was quite clear that although it had, because it had been out of the ear canal for so long and it had become epithelialized, that this was a glomus tumor, a vascular tumor from the middle ear. And so we had to send him for further tests, CT scans and MRI, and he probably would have to be evacuated out of the country to have a definitive treatment, because they would not have any way to embolize this in Kigali. So I was telling you about the things that we get up to. It is usually a very interesting week when we go away. Here I was in Gambia doing a tonsillectomy for a huge, I had brought all these instruments with me, by the way, because the patient, they didn't have any of these instruments. And so I was demonstrating to the one ENT surgeon that they have how to do the tonsillectomy. And this headlamp also was brought along and left behind. And here I was demonstrating and supervising one of the ENT surgeons in Kigali to do a tympanoplasty. And here was the ENT surgeon in Butare that I was supervising to do a tympanoplasty as well. So the interesting thing about going away and working in an environment where you don't know the system, it's a little bit different, is that you have to think laterally, right? So here is I learned that to get a head ring, because we use head rings in ENT, you have to make your own. So there I was making my own head ring for my operation, and they had this way of putting your name on your forehead, so everybody would know who you were. Within a week, you don't really remember everybody's name, and it's important to do so when you're in theatre. But it's not all work. It's not all work. Here, you'll recognize this young lady here who is tucking into a nice dinner before she went off to Butare. There I was in Gambia, in Butare. The coffee in Rwanda is to die for. You also get to meet all sorts of different people and animals. There was a monkey that came up to say hello to us in Gambia, and there we were on the beach getting our feet a pedicure on one beach or the other in West Africa. So coming towards the conclusion, I think the lessons that I've learned and the things that stay with me from these humanitarian missions that we do is that I have to keep on collecting stuff, because even if we didn't take this stuff, which was which is no use to anybody here, then the people over there wouldn't have any. So that's one thing. The second thing is you can really make a difference to people's lives. Here is Pacifique, one of my patients from Butare, who had had a constantly discharging ear until we did a tympanoplasty on him, and there he is, really happy. The tympanoplasty worked, and he came to see me in Kigali this time, 3 years after I had done the operation on his ear. And there, I think that exchange and learning from knowledge, you can continue to learn and exchange knowledge all through your life. And I think that that is one of the most important things that I have taken from this. So in summary, going from a chubby little African girl through training as a doctor in Cameroon and becoming an ENT surgeon, giving back to my mother continent, Africa, although I never really I've never really worked in Cameroon or in Africa, so to speak, has been a wonderful ride. And I would encourage any of you who want to go into ENT to just reflect on the attractions and the opportunities and the really charmed life that you can have as an ENT surgeon. And I think that's where we'll end. If anybody has any questions, I've put my email address there at the bottom for you to contact me if you need to. Shall I stop sharing now?
Yeah, you can stop sharing. And yeah, let's open the floor to any questions, please. Fire away. Thank you so much for that. That was fascinating. Any questions from the floor?
Hi. Thank you so much for this talk. This was really good.
You're welcome.
So I was just wondering, do you think, wait, I'll put my camera on. Do you think it's easy for us medical students to take part in these missions, and especially in ENT related missions, and to go to Africa? And is that something that's doable?
And all sorts of different places, yes. So there are a lot of ENT UK, which is the organization of ENT surgeons associated with the Royal College of Surgeons of England. ENT UK have a global surgery division, and they're quite active. So that's one place to start. I know that there are lots and lots of people who do trips to Nepal, where they do ear camps, or to East Africa, or like myself and Wale, to West Africa with the West African College of Surgeons. I see there that somebody said, do WACS offer electives for medical students? Now, I think WACS in itself doesn't, but I think that there would always be possibilities of arranging things. There's, whenever there's a network, you can have networking, then you can arrange anything that you want to. Finella, Ella, what would you say? I mean, you've been on electives abroad and so on.
Yeah, so I recently come back from my elective. I think my biggest advice for that is you don't really need someone to organise and to have a organised elective sort of planned out that you then sort of join. My biggest advice would be anyone you meet, if you've got any interest in working abroad or any contacts, just ask if they could just give you their email. Because if you send out a whole load of emails, you don't ask, you don't get. And I think people are always more than happy to accommodate anyone that's interested, especially as a medical student, if you're able to pay your way. Yeah, I think it's amazing what you can find, and also, to be honest, amazing what you can work out as you go along as well. Sometimes you just have to rock up and then work it out from there.
Absolutely, absolutely, and that's the attitude, right? So and if you rock up, and even as I say, even as a medical student, you have access to all sorts of places in the hospital, so you can actually do the same, although you may not have lots and lots of space. I mean, carrying all those things around entails having lots of space, right? But even if you say to yourself, I'm going to ask in the theater where I'm a medical student, if you have some sutures. Do you have any sutures that are going spare, or just keep the sutures that you don't need, or anything, little things that you can keep? So when you show up and you bring something along with you, it's always such I find that it's always so good to come with something, because when you come with something, you always go away with something.
I think one of the best placements I had on my elective, I rocked up and just arrived at the clinic and was like, hello, please, can I stay for a week? And they were like, yeah, sure. So I wouldn't worry too much about, obviously have a vague plan, but you work it out. People are always so accommodating if you give them the chance to be. And if you bring something, like you said, onto you. I think there's another question in the chat.
Yes. So Grace says, would I be able to tell more about ENT training? Is run through no longer a thing? Well, as you can see, I'm a little bit of a dinosaur. So the currency that I was talking to you about, FRCS, is not that common anymore. Well, it's not non-existent. So yes, ENT training is totally different, and I think it will be worth. I thought about this. I thought that somebody would be asking me this question. I think it would be worth, Finella, if you could get, and I'm quite happy to plug you in if you want, with one of the ST trainees in ENT, maybe to come and talk to you about what it is like now to get into ENT as a core trainee, what you need to do, because there's all sorts of different things that I don't know anymore. And I keep on saying to them, when I look at them, I say, if I had to go through ENT training now, I'll probably not make it. There's so many things that you have to do with the computer that you guys just know how to do. You just have at the tips of your fingers, You're so much more cleverer than we were in those days.
I'm not sure that's true, but that does sound really useful. That's definitely something we could maybe think about putting on a later stage. Any other questions from anybody on the floor?
What a beautiful question. What would I tell a 22-year-old version of myself? What was I at 22? Why did you choose 22? What drew you to otology within ENT? I'll come to that, Ross. Palani, why did you choose 22? Medical student, okay. So because I was a medical student, yeah. Let me see, at 22, I was a fourth-year medical student and I was just getting married. So, and I had been in a relationship with this man for the previous 3 years. So I would probably say to myself, slow down, take it easy. Nothing's running away. But you know what, Palani? I'm still saying that to myself now. Slow down. I take on a lot, and I take on a lot, and I am very, very passionate about whatever I take on. So it's always full on with me. Why otology? Now, I thought that, thank you, you're welcome. I thought otology, I've really enjoyed otology because, again, there's a whole wide variety of things. There was a part of this talk that I had included, but I had to cut out, and that was about dizzy patients. Because a lot of the time, I mean, when I started in ENT, if I picked up a set of notes with a patient's, the GP referral saying, this woman has been dizzy for the past, 6 months, will you please see and advise? It used to go through my heart like a piece of ice. I would be like, oh my God, dizzy patient. Dizzy patients strike fear into doctors all across the board. If you're a GP, as soon as you see a dizzy patient, you give them beta histine. That's it. But you see, otology has so much. You have dizzy patients, and you can have patients who have had acute labyrinthitis or acute vestibular neuronitis, and they've got so many signs and symptoms where you can deduce what actually is going on with them by looking at their ears, by looking at their eyes, their nystagmus, and listening to the story. Dizziness is one where you have to listen to the story, hear the patient tell you what actually happened in order for you to diagnose. Was it acute labyrinthitis? Was it Meniere's disease? Is it acute benign positional paroxysmal vertigo? Those are the three main things that cause patients to have ear dizziness. The rest are in their head, in their eyes, in their neck, in their brain, their mind, in their heart, in their limbs, in their balance system, so many things. On the other hand, you can do little operations like put in a grommet for a patient. That takes 5 minutes. When I was an SHO in Newcastle, I used to do an afternoon list on a Friday of 10 grommets. They used to be in and out, in and out, in and out, 10 grommets, and make such a difference to a child who can hear. And on the other hand, you can do a huge mastoid operation through a little endoral incision, drill out the whole of the mastoid, take out the disease, and their ear is safe again. So there's lots and lots of different things. There's variety. That's what drew me to otology, even within ENT.
It's a good sales pitch. I'm tempted.
But then again, I'm sure if you ask me what would draw, because I do some rhinology as well, I do see a lot of patients with nasal polyps and snot and nasal obstruction. I keep away from septorhinoplasty from patients who have problems with their body image and wanting a nose job and so on. That's not for me. But if your nose is blocked and you need a septoplasty, and if you need your polyps taken out, doing endoscopic sinus surgery, it is so satisfying to have a camera up somebody's nose that is totally full of polyps, and you have what I call the sucker debrider, and have it on there, clear out all those polyps. I call it a deep snotectomy. Absolutely lovely. Clear out all those polyps, and they wake up and they say, my nose works again. It's fantastic.
It sounds great. Thank you for that answer. Are there any other questions from anybody? I've got one. What are the most what have your most amazing trips been? Where's the best place you visited? And why is that?
On a medical mission,
yeah,
or just as a trip? The best place I've traveled to as a trip is to Tobago, where my mother is from, because I get spoiled. The sea is there, the fruits. Oh my God! Looking for some pictures for this talk, I saw some of the pictures of fruit in Tobago. It's amazing. You have to go to Tobago. But the best I think the best medical mission I have been on has to be this last one in Rwanda, in Kigali. And I'll tell you why. Because the medical missions that I've been to with the West African College of Surgeons, where you spend a week working your butt off, but what the thing that is soul destroying to me is having to leave things that you cannot do anything about. That is soul destroying. Leaving, working from the Monday to the Friday, and leaving on the Friday night, leaving theatre on the Friday night, and there's still people sitting outside that theatre waiting to have operations that they're not going to have. Or seeing a child, for example. I mean, I was too heartbroken to show you the pictures and the videos of Mudassir. Mudassir was about 18 months, and he looked like he was 6 months old. He'd had laryngomalacia from when he was born, and it was drastic laryngomalacia. He was emaciated, he couldn't eat, he couldn't put on weight. He looked like all the pictures that you have seen, the horrible pictures you've seen of children, starving children across the world, wherever in war-torn zones. And this is because he had this pathology that he couldn't breathe, he couldn't eat, he was just slowly dying. We did a tracheostomy for Mudassir. We managed to take out the tracheostomy during the week after we had left. But after we left and we had done a release of his laryngomalacia, because just to remind you, laryngomalacia is where you have very prominent aryepiglottic folds. So your epiglottis is generally an omega shape when you're a baby, and then it generally tends to open up and unfold into a C shape. But with laryngomalacia, this doesn't happen, and the epiglottis falls into the airway, and they can't breathe. So unfortunately, after we had left, even despite everything that we did, Mudassir died. And it is heartbreaking when you go, every year you go to another country and you just see all these horrible things that you really can't do very much about. So what I've done with the East African mission is build a relationship with a group of ENT surgeons who I have developing a relationship with. I've taught them a technique of how to do tympanoplasty using the tracheal cartilage and a minimal access approach. So the patients don't have to have a huge incision behind the ear and a big graft taken from the temporalis fascia. And we've done that over the past 3 times that I've been there, and I've seen the patients come back, and I've actually seen how the doctors that I've taught how to do it have done it. I've seen the patients that they've done, and then following through. So for me, that has been very, very rewarding, being able to teach the surgeons to do something and then see the outcome.
Have you found that the teaching is what makes the biggest difference then? That seems to be one of your messages.
Yes, absolutely.
I suppose it's another way of leaving something behind, isn't it? It's
absolutely. Because of course, every little helps. And even in the missions where I've told you about you always remember, as a surgeon, you always remember the failures. You always remember the things that didn't quite come up to scratch. But of course, there were lots, and I mean, we changed lives of so many people. But it's what broke my heart was not being able to do more.
I think it had an interesting one in that sort of sphere, and that that like temptation is like so strong, and that and
that's not unusual.
Has anyone else got any other questions? before we just natter away.
That's a fantastic question. Fantastic, Grace. Thank you so much. Can I ask, do you mind if I ask you whether, can I see you? Grace, I can see. Can you put your camera on? Oh, okay, that's fine. That's all right. I just wanted to know whether you look like me. Because it's very important. Representation matters. It's a beautiful question. Have you, yes, I'm Black African. Okay. Have you, when you ask whether I have overcome, how have I overcome any sexism or racism that I've experienced as a surgeon? It's an interesting question, because what that means is that you already take it for granted that I would have come across sexism and racism, which is absolutely true. How I've come across it is to just work my butt off. It's not always been productive, because you know, you can only do what you can do, right? But in my particular situation, I think that having to be a mum, a wife, a surgeon, a doctor, and all the other things that come from being human have involved so much intersectionality that I have managed to use some to get me over the others. Let me give you an example. When I went to Newcastle as an SHO, my husband stayed in the Trent region. He was training as an obs and gynae registrar, and I was pretty much a single parent. I was on my own in Newcastle with my daughter, who was 4 at the time. It was very difficult as a woman, a single parent, but then what I managed to do was to get on the side of other women who were white, who had a bit more privilege than I did at the time, to help me. So I was in their club. So you find you're in crowd, you find you're in club, and you manage to get by that way. And when you manage to get by that way, you remember the difficulties that you had, and make sure that when you're inside, you talk and provide a voice for those who are not able to be in the room that you're in. So that's what has bolstered me forward. It has been definitely difficult. It's all right, Fenella, no problem. It has been difficult, but it's just a matter of knowing what you want and how you want to get there. You're welcome, Grace.
Have you found that role models and mentorship has played a big part in your career? Have you got any tips about that?
Yeah, definitely. My first role model is my mother. Thank you so much, Tina. My first role model is my mother. My mother left, as I told you, she left her country, a tiny little island, Trinidad, and moved to the UK when she was 17 to go to university. Fell in love with this big black bear of a man, and she went and had the next amazing 30 years of her life, raising 6 children in a totally different country, learning a totally different language, way to speak, way to eat, dealing with racism, because she went from being a mixed race woman that they called the white woman. In my country, in Cameroon, they call her the white woman, right? And she had to deal with a mother-in-law who had never had a foreign daughter-in-law before. She got married to her husband was his mother's favorite, you know. So she really had to deal with some difficult. I mean, if any of you are in relationships and getting married, you know that getting on the side of your mother-in-law is one thing that you have to really remember to do, especially if you're a guy. So my first role model and lessons of resilience came from my mother. I'll say that with my chest. But within the ENT and within surgery, there are huge examples. One of the first ENT professors is first female ENT professors in London, Valerie Lund, made great strides in ENT. In Newcastle itself, where I was an SHO, we had Professor Janet Wilson, who is a woman. I mean, she's retired, but she's a woman. And she definitely being able to stand there on that stage, and you could see as a woman, she also faced sexism. But if she could do it and get through, then why not you? You know, so there have been lots and lots of role models and mentors and sponsors. Because, for example, one of my greatest mentors when I was going from being an SHO to a registrar was a white guy called David Matthias in Newcastle. And he was a consultant. I didn't know him from Adam before I went to work in Newcastle, but he saw the potential in me. I went for my first registrar job and I didn't get the job because, you know, whatever, for one reason or the other. And he said, the next job in this region is yours. We have to look after our own. You're a good girl. You're a good man. We'll get you onto the team. And that's how it happened. So show up authentically, work your butt off, make sure that you keep your networks, get what Carla Harris, I'm a firm believer in Carla Harris, and she calls your social capital. Always remember who you get on your side. Your social capital is very, speak to people, just like Ella said, show up. What can they say? No? Yeah, well, okay, no, bye-bye. I'll go to the next one. More fool you. When I went to Newcastle with my daughter when she was 4 years old, it was the end of the world. It was because I went to Newcastle because I couldn't get a job in Nottingham where my husband was, and it would have been comfortable for me to get the job I wanted at the Queen's Medical Centre as an SHO. But I went there, applied for the job. I didn't get. I know why I didn't get, but then, you know, c'est la vie. I got on the train, went to Newcastle. They said, when can you start? And that was it. It was a tough time driving up and down the motorway. My daughter decided from the time she was 4 years old, she didn't know what she wanted to do, but she didn't want to do medicine because her dad was always off on a Sunday and he only showed up on the Friday. These two doctors were horrible. But guess what? She became a doctor after all. Anyway, this is me just chatting away.
No, thank you. That's great to hear, actually. It's great to hear just, you know, the reality of what it's like and some of the best ways to go about it, and yeah, where to position yourself and how important people are in your career. So thank you very much for that. Unless anyone's got any other questions, does anyone have any other questions? I might just end with one last little question, if that's all right. Yes. So are there, in your opinion, any unconscious biases that you experience in your day-to-day life that are sort of worth being aware of, so that we can identify them and strive not to do them in our careers?
What a wonderful question. You know, I came back the other day from Tesco. I had been to bring my shoes because the sole of my shoes had just come off. I think I had walked in a puddle or something. And in front of the Tesco Extra, which is just not far from where we live, there is it a Mr. Minute or one of those shoe things that do just keys and shoes and dry cleaning, one of those. So I opened the door, walked in, and there was this lady sat there. And I said, can I give my shoes to be fixed? She said, oh, yes, sure, no problem. She looked at them. They'll be £7.50. Can you come back tomorrow? You can pick them up tomorrow. And I said to her, what, is the man not around? And as soon as I said it, my heart dropped to my boots. And I thought, shit, what have I just said? I just assumed that she was not the person who was doing the job, because a shoe mender is generally a man. So I tell that story to say we all have bias. We all have bias. We all will put our foot in it. The thing to do is to grab that uncomfortable moment and not just slide it by. Because what I did then was I said to her, I actually used the F word. I said, F me. I don't believe I've just said that. I am so sorry. The reason I said that was because I assumed that you were not the one going to be doing the fixing the shoes because you're a woman. And that is so wrong. I apologize. So the bottom line is we all have bias. The thing is to be aware. And if somebody pulls you up on it, or even if you pull yourself up on it, then make sure you deal with it. Make sure you deal with it. You apologize for it. You explain why, and make sure that you make the person who has been at the receiving end of your bias understand that you will do better. And I think that's all you can do.